Hello, everyone. Thank you so much for joining us, the International Bipolar Foundation, for our webinar, Bipolar Disorder in Older Adults with a Focus on Cognitive Functioning. I'm honored to have and introduce our two presenters today, Alexandra Beunders and Annemiek Dols. Alexandra is a resident in psychiatry in Amsterdam, in the Netherlands, studying to get her PhD with a specialization in bipolar disorder in older adults, where Annemiek is a psychiatrist located in Amsterdam as well, with over 10 years of experience specializing in treating older age patients and striving to reduce stigma on mental health issues. Thank you so much for joining us today.
Thank you very much for having us and for your nice introduction. We were very honored to be invited to give this webinar. Weren't we, Alexandra?
Yes, thank you all so much for this invitation. We're really looking forward to it. I'll just start sharing the screen of the presentation and then Annemiek can go ahead.
Yes. In Amsterdam, it's the evening. We're getting ready for dinner, but you can see outside it's dark. Different from the US, and here we go. We will talk about bipolar disorder and as patients are aging, what is changing. So I will give some general introduction on older age bipolar disorder, and then Alexandra, she will talk about one of her most recent, I think, high impact publications that is really addressing the issue of what about cognitive functioning in later life. So what is older age bipolar disorder? As you can imagine, patients with bipolar disorder, they age. And this is a group of the older age bipolar disorder, and they may have the illness all their lives. So it may have started around their 20s, and they may have had episodes, and now they're in their 60s. Or it may be that they've had only depressions in the past, and now when they're aging, they have their first mania. So then this is a converting bipolar disorder. Or you can have the late onset bipolar disorder. In this case, patients, they have episodes all their life, no episodes, and the first episode is after the age of 50. And this may be sometimes even due to somatic causes, and then we call it secondary mania. This may have a different origin, but we are not sure. So as a psychiatrist, treating the patients that are over 60 with bipolar disorder is very interesting, because some of them, they have the illness for so long that they are quite experienced in dealing with it. And then others, they've had a quite normal life with no really mood swings. And then when they age, this is when it starts. So that is also very interesting. And this is why I think that we need to have more attention for the older age bipolar disorder, is because we are awaiting the silver tsunami. The number of patients with bipolar disorder that are over 60 will grow. It has been doubled since the 80s, and it will even be more and more in the next decades. So these are the numbers from the United States. So the number of patients that are 80 and over will be 4 times higher by 2050. And then the adults that are aged 65 and over will outnumber the children that are younger than 5. And in 2050, the elderly will outnumber the children that are aged under 14. So you can see that the absolute number will increase, and on one hand, this is a good thing, so we can have more patients to gain more experience on what would be the best strategies for treatment. But in spite of this growing number, there's very little knowledge. So there is a lot of work to do to gain more insight in if there are changes when people age with bipolar disorder, and if there are, what is the best treatment. So this is why the sister organization of your organization that we are talking about today, the ISBD, the International Society for Bipolar Disorders, for the clinicians and the researchers, they have a task force that is especially dedicated to the older age bipolar disorder. And this has a representation from all over the world, and it's growing. I think this was in Miami, was several years ago when we could still travel easily around the globe. But every year more people join us, and we came up with goals that we share around the globe, and that is that we think we need to combine forces to gain more insight in the aging of the patients and what is the best treatment. So the first paper had several take-home points, and one was that there are no large-scale controlled trials that are aimed for older patients with bipolar disorder. So we have no evidence on what is the best treatment. And then we think that lithium, although it was often regarded as something with a lot of side effects, is potentially very useful in older adults with bipolar disorder. And there is less data on the use of other medications like lamotrigine or atypical antipsychotics. Then there are no psychosocial studies specific for OABD. So we don't really know if it is effective to offer psychotherapy, when you would think that this would be something that patients would really like because it has fewer side effects than medication. So what we do need for the coming decades is well-designed and adequately powered treatment studies in older adults with bipolar disorder. Then we looked at the international guidelines. What do they say about the treatment for older adults with bipolar disorder? So we did a guideline check on 35 guidelines from 6 continents in 19 countries that were published from 2005 to 2015. And most guidelines on bipolar disorder, they have no separate section for older adults, while this is almost approximately half of the population that we are treating with bipolar disorder. So in general, they just say that whatever works for the working age adults is probably going to work for the older patients. And they are not based on scientific data. So again, we conclude that there was a critical need to achieve more data and evidence to guide the treatment decisions and future research. Okay, so we were very lucky that the Bowden-Massey Award was given to the older age bipolar disorder group that initiated the Global Aging and Geriatric Experiments in Bipolar Disorder database. So what we aim with this is we just asked from all over the globe if people have studied older adults with bipolar disorder and if they can share their data with us. So we started this 3 years ago, and now I think in the first wave, we had 1,500 patients, and now it's almost 5,000 patients from all over the globe. You can see that there is a little bit overrepresentation from the United States, of course, because they're very active when it comes to research. But we have some from Europe, South America, even Asia, Australia. So I think we are really pioneering here in getting the global perspective on such a important disorder. So what is specific for older adults with bipolar disorder? I think there are a few things that can become more prominent when people age. And the first is medication, then it is the lifestyle, then it is somatic health, physical health, and then it's cognition. And I will address each of them very briefly, and then Alexandra will really dive into the cognition part. So one of the problems for people when they age is that they become more vulnerable for side effects. So even if patients have used some medication all their lives, when they are aging, they can get new side effects. And you can also see in this graph that with aging, the number of side effects is just increasing. And then it is on top of each other. So if patients use one medication, they have more chances to have side effects. But if they have used two medications, the side effect odds can even triple, and so on and so on. So this is very important, and it's very has a huge impact on quality of life, these side effects. And it's very different from the working age population. Next, it's the biological versus the chronological age. So what you can see is that patients, when they age with a psychiatric disorder, they can age a little bit faster. So in this graph, you can see the blue line, and it is normal aging, whatever we consider normal. So that means that if you are 60 years old, your body is 60 years old too. So your chronological age and biological age are the same. Some people, they are healthy agers. So they look a lot younger than they actually are without having any surgery done, of course. And then you have the premature aging. So these patients, they become frail very fast. So they are older physically than their chronological age. This graph is it is a little hard to understand, but I think is an important graph because you can really see what is happening here. So this was a study where it was looked at what happens to people once they have a cardiovascular disease, and they have the time of the hospital discharge from the first cardiovascular admission. So that is what happens on time 0. And then you can see over the years, when do they die? And then in the upper two lines, you can see young people between 25 and 59. And you see in the general population, some of them, after the first cardiovascular admission, they die. And for the bipolar patients, this is a little bit faster. So more people die because the line is a little bit lower. Then if you look at the people who are 60 to 80, you see the different, they all die a little bit, and more patients die after the cardiovascular admission. And you see that the difference between the population, that is the dotted line, and the bipolar is widening. And then if you look at the patients 80 and over, of course, the survival rates are worse, and the difference between the population and bipolar patients is even wider. So what you can learn from this graph is that even if something happens that is not really considered to be part of bipolar disorder, it's a cardiovascular admission, the fact that someone has bipolar disorder makes their outcome, their survival rate, much worse. And it gets worse with age. So now I want to say about cognition. And cognition is a very broad concept because cognition is all the functions of our brain. So it's attention, it's memory, it's intelligence, it's executive functions, social cognition, judgment. These are major domains of cognition. But as you will understand is that, for example, attention you need for everything. Because if you don't focus, your memory will be impaired. And if you cannot memorize anything, it will be hard to do anything because you don't remember what you were about to do. So although they are considered separate domains, they're all connected. So this is what we also view the brain now. So this is the brain in humans, and you see that it's more about the connections between all the areas than that what we used to think like memory is here and there, and then attention is more in the frontal lobe, and we don't really see it like that anymore. We see it more as it all needs to be connected, and this makes the brain even more vulnerable, because if the connections are a little bit less, then a lot of things, they don't go so well. So I think what we all need to realize is that with aging, some things go better and some things go worse. So I don't know the last time you played the memory game with a child, then I actually think it's very hard to win because they are so good at it. And this is what we all know, that memory is best for preschool children. And then with age, you can see in this line, the green line, it becomes a little bit less over time. And you see that for all the other cognitive functions too, the speed of what people can think with, or reasoning, it all goes a little bit down with aging. This is normal. The only thing that gets a little bit better with aging is the vocabulary. And that, of course, we can all understand because you learn more words as you have more, you meet more people, you read more books. So this can actually stay stable or increase a little bit with aging. So what we want to know is if people age, then they are worried about their cognition because they want to remain independent, of course. So then we have these trajectories. So you have the better than average super aging, and this person just all the cognitive abilities, they stay intact. Of course, this person, I think needs to be born. We don't know anyone like that. It may be your vice president now. He's on age and is still very high functioning. But I think in general, normal aging is what happens to most of us, and that is that the cognitive functions, they become a little bit less. Then you see for some people the cognitive function becomes even more impaired, and we call that mild cognitive impairment. This is not the same as dementia, and some people might actually grow into dementia, but sometimes this mild cognitive impairment may also stay very stable. And then when it's really worse and people have really disturbances in their cognitive functions and they have interference in daily living, then we call that dementia. And I think what we do need to understand is what are the trajectories of cognition in the older age bipolar disorder, so we can see if we need to be worry and what we can do about it. So I think if there are any questions, I can take them now.
I don't see any questions just yet. Just as a reminder, anyone can put any questions they have in the chat or Q&A box, and we'll be sure to answer them. But I think right now we can move on with the presentation.
Excellent, thank you.
All right. Well, thank you so much, Annemiek, for this wonderful introduction into the topic of older age bipolar disorder. I am a resident in psychiatry and PhD student, and my topic of research is bipolar disorder in older age. And I work together with Annemiek on this research. And I'm very honored to tell you something today about the research that I've been doing on cognitive functioning in older age bipolar disorder. I will slowly take you through this research. I can imagine that sometimes it might be a bit complicated, or you've got some questions, and please post them, and then I'll try to answer them as good as I can. So just a quick recap of what Annemiek already told us about cognition. I think this is essential to understand before we go on. So what is cognition exactly? I think a nice definition of cognitive functioning is all the mental activities that we need to think, learn, understand, perceive, solve problems, and to remember. So this is a whole lot. And you can then also, if you understand what cognition is, understand what a cognitive problem is. A cognitive problem is when someone gets a problem with one or more of these mental activities. So, for example, someone can have problems with orientation or attention or memories or reasoning, or all of these together. It can vary a lot between people, actually, which of these activities are impaired. And as Annemiek already said, these kind of cognitive problems can really lead to devastating effects on the ability to function in daily life, because you can imagine that if one or more of these activities go wrong or are very difficult for someone, then also work or household activities or hobbies or relationships will suffer from that. And within bipolar disorder, a lot of patients complain about cognitive functioning. I will come back to that later. And this is also why we wanted to research this. Let's see. Oh, yes. Here is the data on that. So cognitive problems are very common in bipolar disorder, and especially in older age, because it also goes together with the normal decrease in cognitive function, as Annemiek just explained. So research has shown that 60%, around 60% of older individuals with bipolar disorder state that they have cognitive problems. And this is something that they complain of. So this doesn't mean yet that it is objectively measured, but this is a huge percentage. So it's a very big problem within the OABD group. And when you go and measure these cognitive problems, when people state that they have them objectively with tests, then we see that indeed there's a lot of these cognitive problems that are present. And it might be a little bit less than 60%, but we think it's about 40 or 50%. And we also see that if we compare bipolar patients to people that are the same age but do not have bipolar disorder, then the people with bipolar disorder do have more cognitive problems than the healthy individuals. And this research has been done over and over again. So this is really something that we know now. And Annemiek just explained that within the older age group, that there are several different types of older age bipolar disorder. So you have the group that has had bipolar disorder bipolar disorder throughout their lives since their youth. And you have the group that only had their first episode after the age of 40 or even 50. And what we now also see from research is that this second group, so the group that has a late onset bipolar disorder with the first episode after 40 or 50 years old, have a worse cognitive functioning than the group that has had bipolar disorder throughout their lives. And before I, let's see. So what we saw in clinical practice, because we both work at an outward clinic for patients with older age bipolar disorder, what we saw in clinical practice is that that not everyone within this group has cognitive problems, and so there's a subgroup of patients that are actually doing well with their cognitive functioning, but there's also this group that has a lot of problems, and they're also measured when we do a neurocognitive assessment. So what we wanted to know with our research is why is this difference? Like, why do some bipolar patients develop a poor cognitive functions, whereas others do not? And this was the main reason we took on this research. So before I go on, I want to explain something about the link between cardiovascular risk and cognitive functioning in the general population, because this will be important for our research later on as well. So if you look at normal aging, then there are some cardiovascular changes throughout the body, and they also influence cognitive functioning. So in this picture, you can see on the left, there's an arrow, and there you can see the different life stages going from young adulthood to very old age. And so in young adulthood, some people have cardiovascular risk factors, whereas others do not. And cardiovascular risk factors are smoking or a sedentary lifestyle, obesity, diabetes, hypertension, high cholesterol, hyperlipidemia. Hyperlipidemia means that the lipids in the blood are high, so that that's also similar to high cholesterol. And so these cardiovascular risk factors, they can lead in middle age, they can lead to atherosclerosis in the vessels of the body, and they start to clot a little bit. And when you age further, then this can lead to heart disease, such as coronary heart disease, like a myocardial infarction, heart failure, and also this clotting of the peripheral blood vessels can lead to obstructions within the brain. And that's also why at very old age, it's very common when people develop stroke or other kinds of brain problems. And these strokes or small infarcts in the brain can also lead to neurodegeneration, so to cognitive decline and dementia. And this is something that is happening in the general population. So currently, we all know that we have to watch our cardiovascular risk factors, that we have to lead a healthy life, and this is what can prevent heart disease or brain disease later in life. But then when we were thinking about this problem in bipolar disorder, we thought, well, could it be that these cardiovascular risk factors could explain why some of the bipolar patients develop this poor cognitive functioning, whereas others remain stable with their cognitive functioning? So this is one of the things that we thought of that could influence this cognitive functioning in older age bipolar disorder. However, this is not probably this is not the only risk factors that we thought of, because there are also some characteristics of bipolar disorder itself that could be related to cognitive functioning. For example, you can imagine that some patients experience many episodes throughout their lives, very severe episodes. Maybe they are admitted to a hospital and then they relapse again, and they have a very severe trajectory of the disease, whereas others might have a less severe form of the bipolar disorder. And some researchers believe that these differences in the type of bipolar disorder and the severity or the number of episodes could be related to cognitive functioning. And another thing that could be, that was something that we thought of before we started the study, was medication use. This was because, well, there are lots of side effects from that could occur with using antipsychotics or benzodiazepines, and it might be that we thought, well, maybe long-term use of these medications could also lead to some form of cognitive decline. So these were the things that we started out with the research. And so the results that I will now discuss are published. You can find them in this article online. And so the title of the study was Cognitive Performance in Older Age Bipolar Disorder. We investigated the psychiatric characteristics, cardiovascular burden, and psychotropic medication. So what did we do with this study? Well, we included patients from our outward clinic in Amsterdam. And we have a large study that is still running. It's running since 2012. It's been set up by Annemiek. And until now, there are more than 220 patients within this study. And of this big group, 172 patients had an extensive cognitive assessment. So we included 172 patients aged 50 years or over, and we collected all kinds of information from these 3 categories of risk factors. So we collected data on the psychiatric characteristics, on a cardiovascular risk, and also we performed an extensive cognitive assessment. So just a little bit on what a cognitive assessment is. We performed 13 short cognitive tests, and it might be that some of you are familiar with the cognitive assessment, but if not, I've put some examples on the bottom of this slide. For example, on the left, you can see a Maze's test. Here, the participant has to start at the cross and then go as quickly as possible to the exit of the maze, and then we time how fast that was. The second is a Buds rule shifts card. There, different cards are shown one after another to the participant, and then the participant has to perform a task. For example, say whether the card is red or black, and then the rule changes so that we can know how fast the brain can deal with these rule shifts. Now, trail making test is the third picture. There, the participant has to connect the 1 to the A, and then to the 2, and then to the B, and then to the 3. So you can see you have to alternate the letters with the numbers, and that is also timed. And the fourth example is sequences of numbers, where the participants has to remember these sequences and then give them back to the researcher. So we performed 13 of these cognitive tests. In the end, we used 12 for the research, and every test represents a different or sometimes the same mental activity. So here you have the list of the 12 cognitive tests that we've performed, and also the different domains that are measured by these tests. So we have measured the cognitive domain of attention, of learning and memory, of verbal fluency, and of executive functioning. And each of these domains were measured with several tests. And then we also calculated a composite cognitive score. So that is an overall cognitive functioning score, which was the average of the 4 domains. So this was measuring really overall performance. So again, to repeat, we investigated 3 categories of risk factors that could have an influence on cognitive functioning. We didn't know whether that was the case, but we thought about it, and we read in earlier literature whether it could be possible. These could be possible risk factors. So we investigated a lot of different factors. And now I'll present the results. So first of all, we created a model that could predict the cognitive functioning within our older age bipolar disorder group. And the factors that came out of this model were a number of hypomanic, manic, or depressive episodes, having a late onset, having 5 or more psychiatric admissions, smoking, metabolic syndrome, and benzodiazepine use. And just a quick note, because we know that cognitive functioning is decreasing with age. So we controlled for age and for education level, because we know that these 2 factors will influence cognitive functioning. So we looked at which factors are apart from age and education level could be of influence. And so as you can see, if you look at this collection of factors, then you see actually that it's not one of the 3 categories that is influencing cognitive functioning. You really see that there are factors from all of the 3 categories. So you have psychiatric characteristics, you've got cardiovascular risk factors, and also medication use. So then we look, now I will show you which factors were associated with worse cognitive functioning, because what I just showed you was more like a general prediction model. So the factors that really came out of the study to negatively influence cognitive functioning were having a higher age, 5 or more psychiatric admissions, metabolic syndrome, and benzodiazepine use. So again, actually, there are factors from all of these 3 categories influencing cognitive functioning. So I will now go a bit more into detail into the psychiatric admissions and metabolic syndrome and benzodiazepine use. As Annemiek already explained, that it is also normal that cognitive functioning is declining with the increasing age. So I will skip this. So 5 or more psychiatric admissions. Well, we thought about this result and we thought, well, maybe it's not particularly the number of episodes that someone is experiencing throughout their lives that is affecting the cognitive functioning, but maybe it's the severity of the episodes, because we believe that 5 or more psychiatric admissions, that shows that someone really had severe episodes. So that could be an explanation for this finding. But there's also an alternative. It could also be that it's not the psychiatric admission itself that was deleterious for cognitive performance, but that maybe there are other factors connected to the admission that are influencing or have influenced the cognitive functioning in the past. But we actually think that the severity of the episodes is most important here. So metabolic syndrome, I'll quickly explain what it is. Metabolic syndrome is a cluster of conditions that occur together that show whether someone has an increased risk of heart disease, stroke, and type 2 diabetes. And so this is a measurement for cardiovascular risk, but it is really a cluster. So this shows that the strongest influence on cognitive functioning is not either hypertension or either obesity, but really a situation in which they all occur together. And then finally, benzodiazepine use. Well, we think that this could be a short-term effect on cognitive testing, because as you know, if you take a benzodiazepine, people get a little bit drowsy, a little bit sleepy. So if you have to perform on these tests, and you have to, for example, find the exit for a maze as quickly as possible, then you can imagine that this will be a little bit slower if you are having these medication. But it could also be that there are some long-term effects of benzodiazepine use, but we cannot conclude that from our data. It could also be that people that take benzodiazepines are sleeping very poorly, and that it's the sleeping that leads to worse cognition instead of the medication use itself. We don't know that yet, so this is all very interesting to research further. But we do know that within our older age bipolar disorder group, that the people that take benzodiazepines are performing more poorly in the cognitive tests, but also are experiencing more physical diseases and are functioning worse overall. So we think we can conclude from this data that it is not advisable to prescribe benzodiazepines for a long time in this population. So to conclude, we have researched a sample of patients with older age bipolar disorder, and we've, in particular, we looked into psychiatric characteristics, cardiovascular risk factors, and benzodiazepine use. And actually, factors from all of these 3 categories were associated with cognitive functioning. And in particular, higher age, 5 or more psychiatric admissions, metabolic syndrome, and benzodiazepine use were related to worse cognitive functioning. So we believe that our findings stress the importance for clinicians as well as patients to prevent severe episodes leading to admission, but also really monitor cardiovascular risk and physical health, and also prevent the incorrect use of benzodiazepines. So we think there's a task here for the clinicians also to not only look at the psychiatric functioning, but also at the more complete picture of how someone is functioning. So I've come to the end of my talk. Thank you very much for listening, and yeah, the floor is open for questions.
Thank you guys so much. That was so informative and so thorough, and You shared so much great and pioneering information, and we're so grateful. If anyone has any questions, they can leave them in the chat. But first, we have a question from one of our audience members on Facebook Live, and she asked, can practicing memory and brain games help keep memory loss and cognitive functioning from declining faster?
So, Annemiek, do you want to answer this, or maybe it's nice to mention the brain train study in this regard?
Yeah, so I think we all want to maintain our cognitive abilities. So a lot of people, they search for strategies. What can I do to keep my brain? And I think for like specific brain trainers, like cross puzzles, or it's not really proven that it's going to help. What is shown over and over again is that what you don't use, you lose. So it is important to keep thinking and to stay active, and also to continue to do challenging things. What is also important is to keep moving. So if you walk or you run or you like climb the stairs quite quickly, then your blood is going so through your body and also through your brain, and that is really healthy for the brain. So we did a study where we had people walk twice a week in the forest, and once a week we did like strategy training, and that is actually really helpful. So strategy training is more than training just like Sudokus. It is more like, it's like when you go shopping and you make a list before you leave. That prevents you that you are in the store and your memory is not completely there, and then you forget all these things. And there are a lot of strategies like that can be helpful to make sure that you stay independent. So that is more helpful. And I think what is even above that is helpful is not to be too worried about your cognition, because once you get a little bit stressed, then of course everything is going wrong. So it is always good to try to stay calm.
Yes, definitely. That really emphasizes the point that mental and physical health are so intertwined. So great to know. One of our viewers asked, do symptoms or illness severity tend to get worse with age, or is this really a case-by-case basis that depends on the individual? And how can we prevent, as you stated, severity can affect cognitive functioning in the long time? How do we ensure that that severity does not decline?
Yeah, I think I can answer this from clinical practice, and then maybe Alexandra can say a little bit about it on what we studied. In clinical practice, I see some patients that really have more life experience, so they are much stronger when it comes to triggers that can inflict an episode. So when they are younger, they don't know themselves that well, and they're like a little surprised, but what is happening today? And they get triggered and they come in an episode. But when people age, the life experience is really helping them to get some more balance. On the other hand, what I see a lot is that the physical health. So if people get like a urinary tract infection, then that can trigger an episode. So this, of course, is more often there when people age. So for some people, they get more stable because they have the life experience. For other people that have struggling with their physical health, it might actually get worse because the physical health imbalances may trigger episodes.
Wow, that's so interesting, but it makes a lot of sense. Thank you so much for sharing.
And also, I think to add to that, the social functioning is also a very important aspect of bipolar disorder in later life. There are some people that remain to have a very active life, a lot of volunteer activities, or a lot of family visits, and you see that that is also keeping them active. Whereas for others, there is really a struggle with entering this new life phase, and maybe loneliness, and difficulty to still find things to do, and that also influences mental and psychological functioning as well. So it all in older age, this is also why it's so exciting, I think, in clinical practice, but also in research, that physical health and psychological health and social health are all intertwined, and you cannot really take them apart anymore.
Wow, that is so like interesting. It just really shows that it's all about the whole body as a aspect. Thank you so much for sharing that. Another question, you guys mentioned there aren't as many studies about older patients with bipolar disorder. Are there any barriers specifically to hosting those studies, or anything in particular that makes it harder to have those studies being conducted?
I think for like medication trials, then they often say that if you have like one somatic disease, then you should be excluded. And then, of course, you're going to exclude all the patients that are a little bit older.
Yeah.
So I think that is a problem. And the other thing is that it was considered not very sexy to study older patients. And I think that changed. Now there is a lot of interest for the people, how they grow older. And so I think it changed in the past decade, but I think we still need all hands on deck to continue our work.
Well, absolutely. I'm so glad that you both are leading that charge and creating that great work for us. Another question, this kind of speaks to Annemiek's personal mission to reduce stigma. Do you see that older patients have any less internalized stigma because they've lived with this disorder, or do you feel that late onset patients face more stigma because it's so new and different? What's your take on this?
Yeah, so I think it also varies, and that some people they think now that I have less social obligations, I don't care what people think about me so much. So I'm more open about it because they don't have to explain everything in the workplace. And others they are from a generation where it's not so common to be open about how you feel and to be open. I think that is actually for all ages that we prefer to talk about the things that go well instead of the things that don't go so well. So I think in the older age, yeah, I think it's actually getting a little bit easier for people because they don't feel like they have to keep up appearance at the workplace.
Yeah, absolutely. I've spoken with a couple people living with bipolar disorder that are into their 60s now, and they say that they're speaking out with their story more often because they want to reduce that stigma and don't have as much at stake. Whereas younger people, they have to work and have a career. But luckily, we have older folks that are leading the charge for us. So we're super grateful for them.
And I think that the older patients with bipolar disorder, they can really be a role model of someone who survived all the episodes and they're still there. And often I think they're really cool people because they experience so much in life that they become like really interesting people. So I really hope that they can be the role model for the new generation.
Absolutely. We're so happy. If anyone's watching this right now that's an older patient with bipolar disorder, we're so glad that you're here and being a great role model for us. And then one more question is, so you discussed a little bit about late onset bipolar disorder. Do you have any information on how late onset bipolar disorder is triggered? Is it by stressful events or a stressful moment, or is it just something intrinsic that we haven't quite figured out yet?
I think we still don't know why some people, they get it at a younger age and some people get it at an older age.
Okay, yeah, that makes sense. More studies are just needed.
Yeah.
But Annemiek, do you also have the experience that there are some women that experience their first manic episode within the menopause period? I think that is something that we do see in clinical practice, and I think it's a shame that we haven't performed many studies on it, because I think there is a link between hormonal influences and having this first episode after the age of 50. But that's not the complete picture as well, because I think, for example, if people get a stroke, then a lot of the times people get some kind of hypermanic or manic state afterwards as well. And this is what we call secondary mania. So this is a manic episode due to an underlying physical cause. But it could also maybe explain us something about what's happening to the brain. Maybe in some patients, the brain gets more vulnerable due to aging or small infarcts. And then this could also lead up to this manic episode. But so we don't know yet. So I agree with Annemiek that a lot of research still needs to be done, but I think hormonal influences and cardiovascular risk factors definitely play a role there.
Definitely. Well, thank you so much for sharing. We have time for one more question. David from our why was diet not more part of this research, or how did that play in? There's been some research that omega-3 fatty fish nutrition is really critical, and he spoke about his own success in that, and we're wondering if you have any insight in that in your research.
Well, thank you for the great question. I think in depressive, when it comes to major depression disorder, research on omega-3 fatty acids have become more and more common. But for bipolar disorder, this has not been a topic of recent research. And for this research, we use data that we collected since 2012. So back then, even I think in depressive disorder, fatty omega acids weren't really a hot item yet. But it's definitely something that maybe future research could look into.
Awesome. Well, I think that just wraps it up and shows that more research needs to be done, but you guys are leading the charge and we're so grateful to have you in the field. Thank you to everyone for joining us, but especially Annemiek and Alexandra. We're so grateful for you sharing your insights with our community and furthering the research and knowledge about bipolar disorder. If you enjoyed today's webinar, please make sure to subscribe to our YouTube channel and give us a like on this video, as it helps us out a lot. Thank you again to everyone that joined us, and we're so grateful for you all.
Thank you.
Thank you all very much for the great questions as well, and take care.
Bye-bye.
Bye.